Thank you, Dr. Arun, and good afternoon, everyone. And we will start the first session, CDK4/6 inhibitor in breast cancer. As we all know, CDK4/6 inhibitor is one of the most important drug in hormone receptor MBC, and new roles are also coming in the early breast cancer also. And for this session, I would like to invite our esteemed chairperson, Dr. Ranga Rao sir, Chairman, Paras Cancer Hospital, Gurgaon, Dr. P.K. Julka sir, Senior Director, Max Institute of Cancer Care, Lajpat Nagar, Dr. J.V. Sharma sir, Senior Consultant, Medical Oncologist at Action Cancer Hospital, New Delhi. So I request Chairperson to proceed.
Right. Yeah. Thank you very much for invitation. And then nice to be here with my co-chairpersons, Dr. Julka and Dr. JB, who are good friends and very good oncologists. I think wonderful initiative by Dr. Arun and the whole team to talk about the breast cancer management and recent advances. That too in the tough times. CDK4/6 inhibitors in the recent past have made a huge change in the management of the metastatic breast cancers. I think all of us have seen it, and we had one molecule, then the second molecule, and the third molecule. So issue is not whether they are useful in metastatic breast cancer. That's, I think, settled. Then there were some questions lingering in our mind saying that should we give it to all patients? Are there some patients whom we can exempt them and all that? I think most of those questions have been answered. There are very few questions left in the metastatic breast cancers about the CDK4/6 inhibitors. And I think we have now. The question now is whether it can be used in the early breast cancers where ERPR positive, hormone positive breast cancer is HER2 negative. Can we use it to benefit of the patients? Can we use in the neoadjuvant setting? Can we use it in the patients where post chemotherapy, post hormonal therapy, there's some residual disease? Can we improve the results of the PFS or the recurrence-free survival or the OS in these such patients? I think how optimally to use in the other setting than the metastatic breast cancer. I think that's what we need to understand more and more. Let us listen to all the things. I think we have very good speakers down the line here. First thing is in the advanced breast cancers, we have Dr. Ullas Batra, and now he is specializing also in the breast cancers apart from the lung cancers. So let's listen to him from about the evolving strategy in the treatment of HR positive, HER2 negative advanced breast cancers. Over to Dr. Ullas. Oratory skills and his knowledge and all that is very well known to all of us, and we look forward to a wonderful deliberation from him.
Thank you, sir. And thank you for reaffirming that breast is in fact a part of thorax. And I hope this goes on record. And this I didn't say, Dr. Rao and Dr. Dinesh Singh and everybody said. I would like to say that. And this is just, I am just an innocent bystander. Okay, not so innocent. Okay. So I've been asked to speak about evolving strategies in the management of ERPR positive and HER2 new negative breast cancer. And my first thoughts, when I first read the word evolution, went down to the COVID virus. The way COVID virus has evolved. I thought एक बार दोबारा COVID virus से बात तो नहीं करनी है, but thankfully that is not really the case. And I really hope, having heard everyone that a lot of our caregivers and everybody's families are getting infected, I would really want that everybody should stay safe. This is the time when we really need to be at our medically and best in collaboration with each other, and we really hope that all the healthcare workers, all the people of India would really stay safe. So let me start with my talk with a case which basically is of a 60-year-old female who presented with a lump in the breast for 6 months. She had a true-cut biopsy, which was ER90, PR90, HER2 new negative. PS1 bone scan was done, which said multiple bony mets. CT scan done, which said bilateral pulmonary nodules. And CT abdomen had shown few liver lesions. So we have a lady who has got advanced CA breast, ERPR positive, but is ECOG PS1, but has got visceral involvement and skeletal involvement. So how would we treat this patient? I think someone like Dr. Ranga Rao and Dr. Julka, they would have used all these regimens in their career, single agent, combination, tamoxifen, AIs, mTOR, fulvestrant, fulvestrant and anastrozole, and now the latest things which are coming. So, this I have kept this in order to make sure that, everybody say, they have actually given all these things. So, and this is exactly, the timelines of all the agents that we have for hormonal receptor positive and HER2 negative, starting from tamoxifen to Migase to Goserline to AIs, then to everolimus exemestane, then the CDK4s and the alpelisib and stuff like that. So let's go back in time and find out when did it all start. Did it start back somewhere in 1977? Or did it start even earlier than that? And this is for the DNB residents actually over here. So let's look back to move forward actually. And this was the article which was there in 1896, which was by Sir George Bates.
Ullas, your slides are not moving.
Sir, abhi bhi nahi?
No.
No, they are not.
Where am I now?
You are on the first page only.
First slide.
Fantastic.
Yes.
Wait, let me just see. I'm so sorry. Just give me 1 second, sir. Okay, let me make this full share. And can I, is it visible now?
Yes, yes. Visible,
What,
but change
is it
the slide first.
slide that we are seeing?
Try to change the slide. This is okay. Okay, now it's moving. Yes.
Okay. So this was the first article in 1896, which basically said that when Sir George Bateson actually did oophorectomy for a patient of advanced CA breast. He first did this surgery in 1896. He reported on 3 patients in Lancet Oncology. They had significant tumor regression. They had a sense of well-being, and was subsequent report for where a patient survived for 4 years after the surgery. However, the procedure never became popular because of high morbidity, not curative, and there was no therapeutic rationale at that particular time which said that this could actually work. So let's go further. So we were in 1896. It took 30 more years after the oophorectomy was first explored for the discovery of estrogen. Now that happened in the year 1929, and this was the BMJ report which said, the report on the first synthetic estrogens in the malignant disease. So 1896, George Bateson. 1944, it basically came down to the estrogens. It took another 30 years or 20 years after that to develop tamoxifen. Now, tamoxifen was not developed as a cancer pill. It was developed as a contraceptive morning after pill. It never, although proved useful in the human contraception, and it was eventually found to have anti-cancer efficacy in 1970s. So 1896, 1930, 1966, and then we had 1971, in which there was the first study of tamoxifen in advanced breast cancer, in which basically they found out that 10 mg dose has found to have a good dose over there, and the drug was found to be very, very, very useful. In 1973, the first work was done on the aromatis inhibitors in the treatment of breast cancer, and we all know, and this was published in somewhere in 1973, 1974. And subsequently, more potent, more specific inhibitors were basically developed. We all know that the non-steroidal class, they bind reversibly. The steroidal class, they bind irreversibly. And that is how the things came. So from 1896 to approximately 1990, all that we had was only and only tamoxifen. And that was the evolution that we were facing from. Then, so you now have tamoxifen and you have anastrozole. So this, again, the residents should know, the medical DNB residents and all the oncology residents should know, there were trials which had compared anastrozole versus tamoxifen. What did we get? We get a PFS of around 6 months versus 11 months. Anastrozole 8 months, 6 versus 9 months, 10 versus 6 months. So by and large, what we basically knew was that tamoxifen will basically give you 6 months in advanced breast cancer, and the AIs are going to give you 10 to 16 months in advanced breast cancer. And that is what we had almost resigned ourselves to. And that is why probably Dr. Julka and Dr. Rangarao will agree. That is why we look towards chemotherapy, singlet chemotherapy, doublet chemotherapy, because we want to improve on the PFS. We wanted to look more, so we looked at fulvestrant. Now, fulvestrant was compared. So please understand, tamoxifen was compared to anastrozole. Anastrozole came trump. Now, anastrozole was compared against fulvestrant, and in that trial, the Falcon trial, there was a very small PFS advantage of around 3 months. That is 16.6 versus 13.3 months with fulvestrant. But if you look at the bone-only disease, the graph on the right downside, there was a significant advantage of fulvestrant around 24 months, 22.3 months with single-agent fulvestrant as compared to anastrozole. However, if you look at the lung and the liver mets, there was absolutely no difference between fulvestrant and anastrozole. So we spoke about 6 months, we spoke about 10 to 16 months. We again spoke about 16.6 months, which would be we could actually get in the patients of with vascular X. So all the time, all the surgical people used to ask us, fine, you have got a PFS advantage, but is there an OS advantage? You know, the classical thing in the easiest thing to pass in DM medical oncology was you say that there was an increase in PFS advantage, but there is no increase in OS advantage. And when anybody used to ask a medical oncologist about an OS advantage, this used to be our reaction. You know, we just used to look away. Don't ask this question. PFS is basically increased. Again, please look at the curve on the red box over here. In 2015, we had just 2 first-line agents. That was either a AI or a F plus A agent, and all that we had was 14 to 16 months, and this was in 2015. Now 2015, so from 1896 to 2015, all that we got for by and large 1 or 2 agents. So can we raise the bar? That was the next most important question. And what did we really need? What we needed was we needed more efficacious drugs. We wanted drugs which could increase the PFS-OS. We had the drugs needed to have a good tolerability, preferably oral usages, and we wanted biomarkers at diagnosis and progression. So with this in mind, the CDK4/6 inhibitors were basically developed and put to clinical use. Now, mind it, there are 3 clinical CDK4/6 inhibitors: abemaciclib, palbociclib, ribociclib. But since this is a Novartis-sponsored session, I'm not really going to touch upon the other 2. I'm going to speak mainly about ribociclib trials, and these trials were kind of given the Bahubali kind of thing. You know, they wanted us to improve the PFS-OS, being good efficacious drugs, and while at the same time improve the quality of life. So now let's look at the Mona Lisa trials. Basically, this was the Mona Lisa, and this is not what I'm talking exactly about. There have been 3 main Mona Lisa trials that I'll speak about: 2, 3, and 7. Now, Mona Lisa 2 trial was basically, it had compared ribociclib plus letrozole versus placebo plus letrozole in a post-menopausal scenario. So first trial to come was in the post-menopausal setting. You compared ribo plus letrozole versus placebo plus letrozole, and this trial showed a very early separation of the curves between ribo plus letrozole versus placebo, and you had a PFS of around 25.3 versus 16 months, which was absolutely fantastic. Was there an OS advantage? Not at present. Now, this is which is very, 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 very important. This was the trial which basically looked at Mona Lisa 7. Now, we know that the breast cancer in premenopausal women actually has not really been shown to have a great role actually, and all the earlier trials had actually stopped taking the premenopausal patients. However, Mona Lisa 7 trial actually looked at only the premenopausal women, and in which ribociclib was compared to tamoxifen versus ribociclib was compared was placebo and tamoxifen NSAI. And what we found out in this trial again was a huge PFS advantage of 23.8 versus 13 months. So we always thought premenopausal women, aggressive disease, give them chemo. But this trial actually showed that there was a 45% reduction in the PFS, which was actually a fantastic thing to happen over there. Now, this was a Mona Lisa 7 update which was presented in the SABC 20, and there was an OS advantage which was seen in the premenopausal subgroup with ribociclib and letrozole and goserelin versus only placebo plus goserelin plus letrozole, and the median OS was 58.7 months versus 40 months or 45 months in the placebo arm, which was absolutely fantastic. So this was the first trial to show an overall survival advantage in the premenopausal subgroup. So in the postmenopausal subgroup, you had Mona Lisa 2, Paloma, and Monarch, PFS advantage, but no OS advantage. This in the premenopausal, Mona Lisa 7 is the only trial which has basically shown an OS advantage in the premenopausal subgroup. Now, this was the premenopausal. Now let's look at the second line, for which Mona Lisa 3 compared ribociclib plus fulvestrant versus placebo and fulvestrant. please again note over here that patients could have taken ribociclib plus faslodex or fulvestrant in the first line also over here. So there was some subgroup which took in the first line, some subgroup which took in the second line. And what we again find out over there was absolutely OS advantage, which was seen in the ribociclib plus fulvestrant arm. And this was the PFS which increased. And this was the OS survival, which was the advantage which was seen. And the relative risk in the reduction in the risk of death was 28%. The median overall survival in the first line was 40% in the placebo arm versus not reached, 40 months in the placebo arm versus not reached, and a 28% dose reduction was there. If you have the first line, again the OS advantage was seen. If you have the second line, again the OS advantage was basically seen. Now there are 3 trials which have basically compared CDK4/6 plus PFS. In this trial, basically again, I'm so sorry. In this trial also, what we can see that the Mona Lisa had an advantage of 12.8, Monarch had an advantage of 9.3, and Paloma had an advantage of only 4.6 months. Does that mean that palbociclib is inferior? No, it doesn't mean. It basically means that the length of the level of the pre-treatment increases and the PFS in the control arm decreases. So if you have to use CDK4/6 inhibitor, you should actually use them upfront. That's the take-home message that I will take from there. Now I know there will be no sayers in the medical oncology, which basically says, objection, my lord. My patient has got visceral disease. I want a faster response. Can I give chemo first and then go to CDK4/6 inhibitors? My patient has got a high tumor burden. Will these oral tablets actually work in my case? So we were not. So there are always those naysayers which are there. So let's look at some data. Now, if you look at the data, 76% of people achieved a faster tumor shrinkage in the ribo plus letrozole arm. There was no subset of the disease which actually did not benefit. Both the liver people and the lung disease and the bone disease derived equal benefit from the ribociclib and the letrozole, as did the patient from the so there was no subgroup which did not derive a benefit from the ribo and the hormone therapy arm. Now, what about people who had high disease tumor burden? If they have more than 3 metastatic disease, we as medical oncologists, some of us are very chemo hungry, and we should not really be, at least in the ER/PR positive individual. And there was a 55% reduction as compared to what you see if you give only letrozole. The median PFS in the patients who had more than 3 sites of diseases was actually 19.3 versus 12.8 months. So again, as long as the patient is not in visceral crisis, we should probably not use a chemotherapy in the ER/PR positive HER2/neu negative subgroup actually. Now, what about time to chemotherapy? The moment a lady walks into your clinic, the first thing she says is, I do not want chemotherapy. Can I actually have something which will delay the chemotherapy? And the median time to chemotherapy in the patients with ribociclib plus letrozole was 32.9 months. Remember where we started from? Tamoxifen 6 months, AI 10 to 16 months, Faslodex 16 months. After that, they had to take chemotherapy. But if they get ribociclib plus letrozole, you have a 32.9 months advantage before you give chemotherapy. And I'm not even talking of alpelisib right now. So these are the comparison of the trials, which basically says that the OS actually has increased. The OS data, which has been there, has been most importantly for Monarch 2, Mona Lisa 3, and Mona Lisa 7. The postmenopausal OS data is pending, but for premenopausal, Mona Lisa 3 is the only trial which has shown an increase in the OS advantage also over here. So this basically definitely calls, and this is a winner, and definitely CDK4/6 inhibitor deserve to be over the moon with this. However, just when you thought it was all getting over, abhi picture baki hai. There is something more to come in this. Now I showed you this wonderful graph, which everybody was very happy. The blue line with ribo-letrozole was above the yellow line by a far mile. But if you look at this line, actually 45% of people will not respond to a CDK4/6 inhibitors and a letrozole after 2 years. So what about the rest of the patients? What about the rest of the patients who do not respond or who get acquired or a primary resistance to a CDK4/6 inhibitor? Now we know by the way of rebiopsy that PIK3CA mutation is the most commonly mutated gene in the HR positive HER2/neu negative. it is also said that patients with a PIK3 mutation have a worse prognosis. So that is, if you have a PIK3CA gene mutation initially, you will not do that well as compared to if you do not have a PIK3CA mutation. Now, this is the PI3K pathway, which basically says that the PI3K is involved in the production of PIP3, which activates the AKT. And that if you have a mutation, this pathway goes array, and you have a malignant transformation, cancer progression, and endocrine therapy resistance. So you know that the problem is there. You have a PIK3 arrangement which is there. It's very, very simple. You block it. You know, it's I mean, as Sherlock Holmes would say, it's elementary, my dear Watson. So has PI3K inhibitors been tested before? Yes, they have been tested before. You had first generation, you had second generation, you had third generation, and the results with the first generation was absolutely dismal. In the first generation, the buparlisib plus fulvestrant was compared with placebo plus fulvestrant, and the PFS was only 5 versus 6.2, 6.3 months. And the pan PI3K inhibitors did not work. It did not have a PFS advantage. It did not have an OS advantage. It also kind of was very, very toxic. So this is what we were all talking about. This is what our plan was, India's plan of recovery from COVID. But the reality is that you will keep on giving the second wave, the third wave, the fourth waves, and this is the reality. So the solution, if your pan PI3K doesn't work, let's be more specific. Let's have a look at more PI3K specific inhibitors. And there is where the alpha-LSLF actually comes, because this is a specific inhibitor of only the alpha isoform of PI3K. It doesn't inhibit the pan PI3K things. It inhibits only the alpha subunit subform. So now, in the SOLAR-1 trial, people were basically randomized who had progressed on first-line therapy, were randomized between alpha-LSLF and fulvestrant versus placebo, or they also took away people who were non-PIK3CA mutant. So what the results showed basically, and I would also like to tell you that you do not need to do a rebiopsy, because more than 90% of the patient had mutational status which was achieved from the archival tissue. The results, fantastic results. Again, there was a PFS advantage in the PIK3CA mutant cohort if you give them alpha-LSLF and fulvestrant. Again, there was a very early separation of curves. There was an increase in response rate. There was an increase in overall response rate. But what happened to people who were PIK3CA negative? The graph on the lower down, which basically shows that that there was no significant advantage of adding alpha-LSLF if you were not PIK3CA mutant. Now, how do you do for PIK3CA mutation? You can either have a tissue biopsy or you can have a liquid biopsy. Again, an update was presented in SABC which says if your liquid biopsy is negative, please go ahead and do a reflex tissue biopsy, because again, there are 15 to 20% of patients which can have a liquid biopsy negative and can still have a tissue biopsy positive. But if you are a PIK3CA mutant, either by a liquid or by a tissue, your response rates were by and large similar. The median PFS was between 10 and 11 and 10.9. So it doesn't make a difference if you have a PIK3CA mutation by a liquid biopsy or you have a by tissue. But if you have a liquid biopsy negative, please go ahead and go back and do a tissue biopsy. This is again a graph which basically shows that the majority of the tissue samples were from the primary tissue versus the metastatic site. So you do not have to go and puncture the liver, especially in this COVID times. If you have a archival tissue, which in breast cancer is not really a major problem to have, you can definitely go ahead and use that sample for a PIK3CA mutation. So I showed you the PFS advantage slide. So what changed in the year 2020? A lot. COVID came. But that was not the only thing which changed for Novartis. Although this is a Novartis sponsored symposium, but I'll be failing in my duties if I do not show you the OS graph. Now this graph again was presented at ESMO 2020. The median OS, which Novartis wants to go and shout on the top, you know, in Mona Lisa 3 and 7, which was a survival advantage. But in SOLAR-1, the median OS was numerically superior, but it did not cross the pre-specified O'Brien-Fleming efficacy boundary. That is, even if the p-value is was 0.15, it did not reach statistical significance. Numerically, you had a 7.9 months advantage, but in the end, this was not statistically significant. However, if you look at, and again, what I wanted to show you was people with lung and liver mets derived great, with bony mets did not derive benefit from this combination, but people with lung and liver mets derived great benefit from the combination of alpelisib and Faslodex, and the HR over here was 0.68. So this was the conclusion which was given at ESMO, that there was a 7.9 months numeric increase in the median OS with alpelisib and fulvestrant, although it did not cross the pre-specified O'Brien-Fleming boundary. The subgroup analysis shows a huge advantage, a better advantage in people with liver and neck and lung mets, and those who had a mutated ctDNA in the liquid biopsy. It delayed time to chemotherapy, and again there was a numeric increase in the OS, but there was no statistical significance. My last two slides. If it's too good to be true, there's something wrong, and there is something definitely wrong. Not wrong, but you need to be careful. Alpelisib is not like imatinib, gefitinib, or erlotinib. There are toxicities which are associated with alpelisib, and the first time I still remember I gave alpelisib to someone on a compassionate ground. I told that lady, "Auntie, chinta na karo, kuch nahi hoga." And then my resident and my colleagues came and told me, "Sir, please have a look at her sugar, please have a look at her ECG, rash, and diarrhea." So I always say a well-informed physician is the best informed, a well-informed patient is the best informed patient. Always have a look, have a baseline HbA1c value, warn the patient they may have the rashes, they may have diarrhea, they may have mucositis. After we have changed our practice, we do give them prophylactic treatment for the rashes. We do give them treatment for diarrhea. We do monitor their HbA1c. We have a very low threshold for starting metformin, and we are educated towards that. Alpelisib has become a slightly more tolerable drug. So my take-home messages in this first talk is, endocrine therapy is a treatment of choice in HR positive, HER2 negative ABC unless the patient is in visceral crisis. In premenopausal, OS advantage has been seen with Mona Lisa Monarch. For postmenopausal, 3 trials, there is an advantage, but no OS advantage seen till now. In second line, postmenopausal, OS advantage is seen with ML7 and Monarch 2. The various CDK4/6 inhibitors are not the same. There is a difference in toxicity profile. There's a difference in the way they act upon the CDK4. Ribociclib and abemaciclib are more specific for CDK4 inhibition. PIK3CA mutation to definitely be tested on progression. SOLAR-1 trial has demonstrated numerically increased survival in second line ABC. And with this, I think I have one more slide. Okay, I think there is some problem with my thing again. Okay, that's it. With this, thank you. And I will hand it back to the organizers. Thank you. And I'm sorry for the technical glitches which happened in between. Thank you.
Thank you, Dr. Ullas. I think for an excellent talk, as usual, it is heartening to learn from you, rather than listening.
April Fool, sir, April के first को मनाते हैं, sir, बाकी दिन नहीं मनाते हैं.
Now, Arun, what about the questions? Shall we have it now, or we'll have it at the end of second talk? Questions?
Have it at the end of second talk.
Okay. Thank you very much, Dr. Ullas. Now we'll have the second talk, and I would request Dr. J.B. Sharma to announce the second talk.
Thank you, sir.
By Dr. Meenu Walia, please.
Yeah. Thank you, sir. Now we will be inviting Dr. Meenu Walia, who is a Senior Director Medical Oncology at Max Super Specialty Hospital, Patparganj and Vaishali. And she will be speaking on navigating management with CDK4 inhibitors, optimizing treatment using real-world experience. So, Dr. Meenu, you can please take over.
So, thank you, JB, and thank you, organizers, for the opportunity. Let me share my slides, and in the meantime, I just hope that everybody is safe and everybody's families are also safe at these difficult times when almost every family seems to be touched by COVID crisis at present. And it was really nice to, even during these difficult times, to hear the chirpy voice of Ullas and the presentation with all the fun. It was really nice about looking at the film stars and picture abhi baki hai. it was nice to, as if the world is the same. So some ray of hope, and very soon the world will be same again. And without wasting much time, I hope my slides are visible. So I will definitely not be as chirpy and as masaledar talk as Ullas, because he's a world apart. But short and simple, I would like to keep it talking about, for the sake of all the student, including the students also, apart from the faculty. So today the talk is, the second talk also happens to be about CDK4/6 inhibitors. And what I will be focusing is not only the clinical trials, but I'll be focusing on the real world evidence. And this has been reiterated time and again, and Ullas also has beautifully captured once again. So in today's date, a hormone responsive, hormone positive breast cancer patient, HER2 negative, not in visceral crisis, not with any life-threatening visceral crisis, the treatment of choice for this subgroup of patient is endocrine therapy with a combination with CDK4 inhibitors. We have multiple CDK4 inhibitors at present, and at least 3 are available in our country. Now it is up to them to decide which one to choose, looking at the typical case scenario. And it is not only in the first line. Once the patient fails this, we know that again in the second line, third line, we can still keep the patient on endocrine therapy. And now that PIK3 inhibitors are also available, these subsequent lines seem to be increasing before we actually go for chemotherapy. So going further, just a second. So CDK4/6 inhibitors, Ullas also captured this thing. So we have various CDK4 inhibitors and the data from various trials. All of these are phase 3 trials. So some have been conducted on postmenopausal women, some have been a combination, and Mona Lisa 7 especially has been on the pre and perimenopausal women. So we have Paloma 2, Monarch 3, Mona Lisa 2, which are all in the first line, and Mona Lisa 7, which is also in the first line, but the subgroup population was pre and perimenopausal. And the combination arm, all of these had a hormonal agent. So majority of them, both Paloma 2 and Mona Lisa 2, had letrozole as the hormonal backbone. And in Monarch, it was non-steroidal aromatase inhibitor. And in Mona Lisa 7, it was being this premenopausal population, we also had gosfrelin injections, and any of either non-steroidal aromatase inhibitor or tamoxifen was being given. So what is important for us, and especially all the students who must have also joined, that if you look at, although cross-trial comparison we generally should not be done, but if you look at the hazards ratio in all these clinical trials, all across the hazards ratio has been 0.5. So across the various trials, 0.54 to 0.57 if we see, both in first line as well as in the second line. So I'm talking about the first line only at present. So hazards, that means, what we mean to say is approximately 50% of the patients, they benefit after the addition of these CDK4 inhibitors in combination to the hormonal agent. So all these patients, all across these trials, there was significant overall response rate, significant clinical benefit rate, and OS data. So OS data, we know that has matured only for Mona Lisa 7 at present. So we have OS data for the premenopausal subgroup at present, where there is an OS advantage also. So OS data for the others are also expected. And just a word for the, again, for the sake of the students, when we say why is it that some of the trials have come with the OS data and some of the trials still do not have their OS data matured, is the fact that in Mona Lisa 7 we are basically talking of a premenopausal, a younger population, where we know that the group, the disease which we are talking about in the younger population is more aggressive, and their median survival is generally less than the postmenopausal subgroup, where the disease is comparatively less aggressive. So that is why probably we have the OS data which is mature for the premenopausal subgroup, and we have the OS data which is also mature for the second line and the subsequent lines. So again, yes, this is now the second line. We have not only phase 3 evidence, phase 3 trials for first line, but we also have phase 3 trials for CDK4 combination in second line along with fulvestrant, and again, patient with multiple lines of therapy. So yes, we have the subgroup of the major, on the broad, the subgroup was the same. It was prior endocrine therapy. Once the patient progressed, these were all hormone receptor positive and HER2 negative. But if we look, go to finer details, so this was not the same population across the trials. So if you look at Mona Lisa 3, 19% of this subgroup was actually a de novo subgroup, with where no previous for metastatic breast cancer, no previous therapy was given. So no previous hormonal therapy was given, and 19%, almost 20%, is quite a huge number. And another 48%, the rest of them possibly were only patients who had progressed on one line of endocrine therapy. So compared to this, again, the inclusion criteria, the population which was included in the Monarch trial, uh, here also the majority of the population was either no previous hormonal therapy, or uh, or only one hormonal therapy. But if we come to the Paloma, here if you see, almost 1/3 of the patient, 33 of the percent of the patient had also received previous chemotherapy. So they were post multiple lines of hormonal therapy and then chemotherapy also. And many patients had received more than 1 and 2 lines of hormonal therapy. So definitely this was a more aggressive subgroup. The group which we were dealing were with post multiple lines of hormonal therapy, and maybe and that is why probably expected to have a lesser survival. Again, you had a PFS advantage, and then again have a closer look at the hazards ratio. And again, I'll say all the DNB students and all the students who have joined, the easier way to remember is zero point 0.5 is something which we have found with this CDK. For the HR ratio has been 0.5, 0.54, 0.50, 0.54 to 0.58. That is all across the trials. So almost 50% of the patients seems to be benefiting. And whether it is being used in the first line again and or in the second line, this is the figure, this is the number which you should remember. And overall survival advantage was seen in the subgroup, where they did some subgroup analysis, and where we can see in the patients who were sensitive to prior endocrine therapy, there was a significant difference with the addition of CDK4 even in this subgroup. So going further, are all CDK4/6 inhibitors same? So again, we come back to, yes, we are seeing all across the hazards ratio 0.5. All of them seem to be working, and all of seem to be making a significant amount of difference in the PFS. Definitely, OS data for some subgroups is available, and OS yet to come for some other subgroups. But the toxicity, if we go to the toxicities are not the same. So toxicity, we know that the major toxicity of all these CDK4/6 inhibitors are neutropenia, QTC prolongation, GI toxicity, liver function derangement, and fatigue. So these are also in the clinical world, in our real world, we see these major toxicities when we are dealing with these subgroup of patients. Neutropenia, quite common all across all the CDK4/6 inhibitors. Yes, much more common with palbociclib and ribociclib. QT prolongation, a very important thing, which we monitor also, especially for ribociclib, is QT prolongation, which we need to see baseline also, and then at least need to monitor for the initial cycles. GI toxicity, again, quite common with abemaciclib and to some extent with ribociclib. Liver function derangement also needs to be monitored both with abemaciclib and ribociclib. Fatigue is seen with all across, with all the CDK4/6 inhibitors, almost in the same percentage of patient. So it is not as, I mean, just knowing that CDK4/6 inhibitors make a difference, just knowing that CDK4/6 inhibitor in combination with hormonal is not enough. We also need to know how to monitor these and what are the monitoring guidelines. So with palbociclib, much more easier to remember, CBC is something that needs to be monitored. Mid-cycle also for the first 2 cycles only, and then subsequently at the beginning of all cycle. With ribociclib, apart from CBC, QTC interval needs to be monitored at least for the first 2 cycles, and then as and when clinically indicated. Apart from that, serum electrolytes and liver function tests should also be monitored. And then abemaciclib, CBC and liver function test, these are the 2 things that should definitely be monitored if the patient is on abemaciclib. So what do we have? We had earlier we had palbociclib only in combination with letrozole, but now we know there is an extension of the indication. It is also approved for combination with any aromatase inhibitor, in combination with fulvestrant also as second line in patients who had progressed. And there has been benefit which has been seen in the pre and perimenopausal women also, and it is approved in that indication also. So what is very, very important for all of us to know is, yes, we have evidence that these CDK4/6 inhibitors in combination with hormonal therapy seems to make a lot of difference. There is a PFS advantage, there is a OS advantage, but again, the real world and the clinical trial world is not always the same. In the clinical trials for this, we have the best of the patients, the best performance status, and excluding all those with the comorbidities. But the real world patient, we all know when he walks inside our OPD, and especially these metastatic CA breast, the older subgroup. So this is not an idle, the patient who not an ideal patient will have a compromised performance status, will have a lot of may have a lot of comorbidities also. So what needs to be seen is the real world evidence also. So is the results as good as in the real world? And we have multiple studies which is actually real world evidence of how these agents seems to be performing, how palbociclib seem to be performing in the real world. So 2 of these are retrospective analysis from the medical records, the IRIS study and the Flatiron analysis. And IRIS has included more than 1800 patients, and Flatiron data is on more than 2.2 million cancer patients across the multiple US cancer clinics. And apart from these retrospective, there's some smaller data from expanded access program also, which is also retrospective. But we also have an ongoing prospective non-interventional study for more than 1500 odd patients, and where the quality of life and other parameters have also been assessed. So Flatiron study, just 2 words about it, because it's a real world retrospective analysis, and the real world data about real patients has included more than 280 cancer clinics, more than 800 sites, cancer hospitals all across, and more than 2.2 million patients from whose database has been collected and studied. So in this retrospective analysis, the randomization process has also been tried based on propensity score matched cohorts, and we have actually been able to have two-line data. So we have two arms, one with combination of palbo and letrozole alone, and they have been matched also using at least two different scores. And if we see the data, then the group have actually been matched looking at the median age, the sex ratio, and the stage of the disease and the performance status. So from this real world evidence, again we see that there is a significant advantage in the progression free survival. The arm which has received letrozole with palbociclib, the median PFS was 20 months, so which is consistent with all the clinical trials where we have seen the median PFS advantage to the tune of more than 20 months, and compared to letrozole hormonal alone arm, which has been only to the tune of 11 months. Then apart from the PFS, again, there seems to be an OS advantage also, and OS advantage with our combination arm as per the clinic, as was evidence from the various studies also, seems to be performing much better compared to hormonal alone. And you see the curves remain wild separated, and the OS not having been achieved so far in the combination. And with letrozole alone, the median OS has been to the tune of 43 months. So this was the Flatiron data, and everything seems to be, again, across the forest plot, everything again seems to be favoring the combination, except metastatic to metastatic site where there is unity, and probably the race non-documented. This I have no reason, and I don't think, I mean, could not explain why it is this, but definitely in all the subgroups otherwise it seems to be favoring the combination. So what is the conclusion? That in real world setting also, so it is not only the clinical world setting, it is not only the best of the patients with limited comorbidities, so in the real world also palbociclib seems to be working as first line combination along with letrozole, much more effective than hormonal therapy alone. And not only there is a PFS advantage, there is also an OS advantage, and these data definitely complement the superior clinical efficacy which has been found in various clinical trials. And the same goes for, because this was all the US population, so the same goes for the IRIS study also, where not only the Americans but the Europeans were also included. And here also we see the PFS advantage, the OS advantage in favor of combination, and plus the result seems to be consistent. For example, in 2 years, more than 90% of the patients seems to be surviving in the OS. So again, so we already know that the PFS is to the tune of almost 20 months, 24 months, 27 months, all across these studies. So this is what we have from the real world evidence also. So in the real world evidence also, this seems to be a very favorable and effective combination in terms of progression-free survival as well as OS survival. And majority of these patients, rather all these patients, were started on 125 milligram in the real world also. And dose reduction has been the rate where the number of patients who required dose reduction were a small minuscule. So real world evidence also is similar to the clinical trials. And we have another study. I don't know whether this siren was the time up, or do I have time?
Time up.
I think,
Ma'am, you have few minutes also. You can continue.
I have how much time? Another 5 minutes, 10 minutes?
5 minutes.
Okay, thank you. So there is a Madeleine study also. So this Madeleine study basically is for the patient quality of life. So it studied the patient reported events, and the study design was very unique in the sense, anytime the patient was started on a CDK4 inhibitors, the patient, both the patient and the physician, was asked to download an app. So this is an app-based study, and anytime the neutropenia occurred, the physician was to register this in the app, and about the quality of life, fatigue and everything, the patient was made to register in the app. So what was found is, although neutropenia was quite common, but it did not compromise the quality of life, and patient had a significant had a relatively a very preserved and a good quality of life, as is our clinical experience also. So Madeleine study also showed, although 45% of the patient experienced neutropenia at some point during the study while on palbociclib, but these patients did not have any compromise in the quality of life and did not fare worse than those who did not experience neutropenia. Again, reiterating the fact that what we have been seeing in our clinical experience and have been using palbociclib for such a long time, that the tolerance is quite good and the quality of life seems to be quite maintained. So that was the Western world. Coming back to home, Swadesh, and what happens in our country. So we have some Indian, fortunately, we have some Indian data also for this. So we have more than 4 to 5 years experience now. All of us, all medical oncologists are well versed with all these CDK4/6 inhibitors, I'll rather say. And yes, by sheer numbers, we have been most comfortable with palbociclib, and we have the data which was presented at EBCC 2020 poster also, and an ASCO abstract also. Retrospective analysis from 2 Delhi hospitals, and one is from Rajiv Gandhi and VLK, one of the largest real world data from our Indian population, more than 188 patients, or approximately 200 odd patients. And again, the reiteration of the fact was almost the same. The median PFS to the tune of 20 months in the first line, in the second line to 11 to 12 months, which is again what we see in our clinical data, with significant overall response rate. And toxicity, only 10% of the patients had grade 3-4 toxicity. Patients had neutropenia, 20% of the patient, but only 10 to 20% had grade 3 neutropenia. None of the patients had febrile neutropenia. So Indian patients also seems to be behaving like the Western counterpart. The quality of life seems to be maintained, and our Indian patients also seem to be tolerating this agent quite well. And again, this is another data. This is from South India, where multiple centers, 5 centers were involved. And again, in on data of 130 patients, and almost similar results, that patients tolerated this quite well. We have the PFS to the tune of 14 months in the second line in this subgroup of patient, and in the first line, the PFS is still not reached. And not only that, again, reiterating the fact that the drug is very, very safe in our Indian population also. Also, although neutropenia occurs in a substantial number, but none of the cases with febrile neutropenia, and grade 3 neutropenia was comparatively very less. So it has resulted in similar efficacy as what has been seen in the clinical trials, and similar safety also as has been seen in various clinical trials and in the Western population. So what are the consensus guidelines, or what do we say, what should be the take home message for all the, especially the students who are here? Patient with metastatic breast cancer, the available evidence does not support local regional treatment. The decision has to be individualized. And in metastatic breast cancer, unless hormone receptor positive, HER2 negative, unless the patient is in visceral crisis, chemotherapy is out. Hormonal therapy, rather combination hormonal with CDK4/6 inhibitor, is the way to go. Combination of, we have the 3 various CDK4/6 inhibitors, and palbociclib is one of the preferred agents in this. We have had maximum clinical data and real world evidence for this. So we have others also, and but whatever we are using, we need to know the our patient, we need to know the comorbidities, whether the patient is suffering from any other disease or not, or taking any other medicine with the QTC. And if at all we are using whatever agent we select, the monitoring has to be very, very proper. So with palbo, we know only CBC. With ribo, apart from CBC, we need to monitor the QT interval and the LFTs also and electrolytes also, and with abemaciclib, liver function and CBC. So premenopausal women can also be given in combination of aromatase inhibitor with CDK4/6 inhibitor. So in addition, we need to use ovarian ablation also. So this is all. ESR1 testing is not recommended in routine clinical practice. Combination of fulvestrant and palbociclib can also be offered. So we have in second line, we have the combination which is approved for second line also, a patient progressing on any of the aromatase inhibitor. Exemestane and everolimus has also been an option in second line and third line. And now that if the patient is PIK mutant, we have an option for that targeted therapy also. So has palbociclib changed the treatment paradigm? So yes, we know that it has changed the treatment paradigm. Earlier than 2015, there were very limited options and only hormonal we could use. And later was our experience with CDK4/6 inhibitors. Now all of us have been using CDK4/6 inhibitors left and right, and we are very confident, especially with palbociclib and the others also we have now started using in our clinical practice. Efficacy wise, safety wise, and quality of life wise, we know that we have lot of evidence. We have lot of evidence not only from the clinical trials, we have real world evidence also now, and from more than 2.2 million patients, and we have real world evidence from our own set of Indian patients also, that Indian patients also seem to be tolerating this drug very well and with good evidence that we have, and the quality of life seems to be maintained. So CDK4/6 inhibitor, and since this is like the older data has been about palbociclib, it is a significant advance in the treatment of hormone receptor positive HER2 negative metastatic breast cancer. Not only in the first line, we have evidence for the second line also. Manageable side effects with minimal side effects, maintaining the quality of life, and having real world evidence, and managing it quite well. So that is the way to go. And that with that I would like to say thank you. Thank you.
Thank you, Dr. Binu. Thank you very much for the wonderful presentation of palbociclib related with real world data also. So if there are any questions.
Dr. Sharma, there are no questions from the delegates that we have received. Okay. So maybe I can ask one question. Do any of you recommend CDK4/6 inhibitors in a high-risk patient as an adjuvant? So we have some data which is going either way, no benefit versus some showing benefit. So maybe Dr. Julka, you and if you can throw some light on this.
Yeah, Dr. Meenu, would you like to say something?
So at present, I am not using CDK4/6 inhibitors in the adjuvant setting. And we know that there were recently some data that was presented, and rather these were negative trials. There has been some, not exactly a positive trial, some evidence that Abema may be working in the adjuvant setting. And but before we have more mature data. So at present, at least, I am not using in the adjuvant setting.
Okay. Yes, we are not using in the adjuvant setting, even though Monarch E trial, has shown that abemaciclib could work in this setting as an adjuvant therapy in high-risk cases. Yeah. Clinically high risk. How do we specify clinically high risk? More than 3 nodes positive. That means 4 or 4 plus nodes positive. T3 tumor, extracapsular invasion. So all these high risk features, if a patient has, then Abema could work with the hormone therapy. So that adjuvant therapy, it has not reached the OS advantage because the time is short. So we have to wait for more time to see if there is OS advantage or not. Then we would be using them in adjuvant setting. Now, one question which I would like to ask Dr. Ulas or Dr. Meenu both why there is more neutropenia with palbo and ribo and not with abemaciclib. Neutropenia, I'm asking. Neutropenia, that means we have more myelotoxicity, these two agents, than with abemaciclib. Abemaciclib has come now, but you must have used it. Diarrhea is the main, culprit.
Ulas is still there or he has left?
Ulas has left?
No. Yes, he has come. Unmute yourself. Okay.
So I think it's got something. You see, all the CDK4/6 inhibitors are not really the same. There's a difference in the level of the CDK4 inhibition which is there. There is also a difference in the level of a free drug which is available. So I think it has got to do something with that, although I do not know exactly the right reason for that. But I think it's got something to do with the CDK, more propensity to cause the CDK4 inhibition and the high level of drug of concentration of ribociclib which is actually available. So
yes, actually, palbociclib and ribociclib are CDK4 and 6 inhibitors, basically. And abemaciclib is more of CDK4, less of CDK6. That is the reason why they cause more neutropenia than the abemaciclib. Secondly, Dr. Ulas or Dr. Mino, any of these, if a patient presents with hormone receptor positive and HER2 negative metastatic breast cancer patient, and patient also presents with PI3K mutation, he gets the foundation done right at the beginning, and P10 mutation. So if a patient presents with this, how would you proceed? Would you like to give chemo? Metastatic
mutations, PIK3 and P10.
P10 mutant and PI3K.
PIK3 mutation.
I'm talking of real world scenario. Means I have a patient like that. The patient is perfectly all right now. And
Dr. Minu, do you want to take it?
I'll take it.
In other words,
Hello.
Some connection problem.
I wanted to ask you about triple drug therapy. Can we use that?
So I have not used triple drug therapy so far, although it is a very challenging thing. And you really do not know. I mean, it makes scientifically, I mean, it makes sense giving this patient, this is going to be an aggressive case, and this makes sense giving him a combination of chemo and with the other agents also. So I would, Ulas, any comments from your side?
No, I think I will take all these NGS reports from Foundation and everything in with a pinch of salt, with the loads of pinch of salt actually. Sir, I think there's a lot that
Foundation one.
So I would like to go in the standard way. I would like to give up CDK4/6 inhibitors, and I would like to give a letrozole. I will tell the patient that there's a high chance that they may not respond. Yes. I will like to call them every monthly, every 15 days to look for clinical examination. I will not like to give chemotherapy right now, sir. I'll hold my horses.
Sir, but can I ask a question there? Just a quick one. So does presence of P10, because it's not a RV1 mutation, not on the same pathway, but presence of P10 and PIK3 make it resistant to CDK4 inhibitors? I don't think I've seen anything to suggest that. In fact, on the contrary, PI3K is a inherent mutation, so it may stay with you for life. And everything is suggesting that the later you pick it up, the better it may be in some ways. So I don't know what everybody else thinks. I just felt that's my view on that.
I would give CDK4/6 inhibitors and letrozole. I will not like to give that. That's what I would do.
Yeah, agree.
So there's an audience question. What about patients having low ER/PR expression? So maybe Dr. Mino or Dr. Ulas could say, if there is a low ER/PR expression, is there any benefit from CDK4/6 inhibitors?
So low will also mean how low?
No,
and
so I think you may have to quantify, because that is a question. So maybe if you can give any quantification.
So what we are doing, like we don't have any data on this. So what we are doing in our real world, like real practice is, if the ER/PR is something like 0/8 or 3/8, I'll rather treat this patient as a more on a negative side. I'll not feel that this is a positive case, and then depending on the disease load, I'll be tempted to give chemotherapies. The same goes for if it is ER negative and only PR positive. I'll be tempted to give. I know that this patient is not going to respond to the hormonal therapy that much. So, but anywhere I say, I mean, there's no cutoff. Looking at the entire clinical picture, the type of meds and everything, the higher the value, yes, there's more evidence to give that. So, but I would want to know from others also what Dr. Julka is doing in his clinical practice.
Yes, you are right. You know, in clinical practice also, if they are less than 50%, you know, if ERPR is say 2 out of 8 or 1 out of 8, that means it is pretty negative. It's not positive. So we don't consider it as positive ERPR. So that
I think less than 10% are to be taken as a cutoff for that purpose. CDK4 and 8.
Dr. JB, if it is less than 10% ERPA, it's supposed to be taken as triple negative. More than that, you look at the clinical situation, how bad the disease is, how indolent the disease is. If it's only bony disease with breast in a postmenopausal lady, let's say even if it's ER30, PR20, I'll be tempted. There is no right answer. I tempted to give CDK4/6 inhibitors along with that. It again depends on the clinical situation that we are in.
And another question is, can these agents be used in some sort of a visceral crisis? Is there any experience?
So, so again, it comes to definition of visceral crisis. So we have those defined subsets. Yeah. I have used abemaciclib with the patient already having LFTs deranged.
Yeah.
For visceral crisis because of the liver mets and all borderline LFTs deranged, and I have found responses also.
Okay.
So, I mean, what is the extent of the visceral crisis and how much you feel that you can wait? So possibly, yes, they can be used. Not exactly if it is a bone marrow disease or it is a CNS disease. So in one of the CNS cases also abemaciclib, because it has CNS penetration. So we have used, although by definition CNS involvement is a visceral crisis.
I think because response rate are very faster and deeper than chemotherapy, at least in impending visceral crisis, we should use CDK4/6 plus AI if ERPR is strong positive. And
yes.
So I think Dr. Gopal, we should call an end to the session. And
so thank you, chairpersons, and thank you, speakers, for a wonderful discussion and wonderful session.